This is She's on Call, a weekly show hosted by ENT specialist Dr. Sujana Chandrasekhar and General Surgeon Dr. Marina Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's on Call, hashtag She's on Call. Please welcome our hosts.
Hello, I'm Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon practicing in New York and New Jersey.
And I'm Marina Kurian. I'm a general surgeon that does minimally invasive surgery, weight loss, both medical and surgical weight loss in New York City.
Welcome to our show. We have a terrific lineup today. Today we're going to be speaking with Dr. Doris Day, who is a wonderful dermatologist based in New York, and Dr. Valerie Fitzhugh, who is a pathologist and the interim chair of pathology at Rutgers New Jersey Medical School and Rutgers Robert Wood Johnson Medical School. They are both what Marina likes to call Twitterati. They have enormous followings, and they have really learned how to teach locally and nationally and internationally. And I think we're going to learn a lot from them. But we are just letting you know again, we are live on Facebook and YouTube and Twitter and LinkedIn and Instagram. We're on scroll.in. Please take a moment to hit like and to share and to maybe tag your friends who would be interested in learning some medicine, spending some time with these amazing women physicians, and sharing in the conversation.
So we have, the other thing I want to let you guys know about Doris Day is in addition to both her and Valerie being Twitterati, and you guys should follow them. But Doris is also a host on Dr. Radio on SiriusXM. And so I've had the pleasure of doing shows with her because I happen to be a host as well on SiriusXM, and she's just absolutely fantastic and a doctor to the doctors, if you will. So we're really thrilled. But first, Suju and I are going to go through some of the news of the week like we do every week, and I'm going to let Sujana start.
So I will be so happy the day that I don't have to do this, Marina. Let's talk about the weekly update on COVID-19. We are not winning yet. The latest U.S. updates from CDC.gov is that there are 5.6 million known cases of COVID-19 in the United States and 175,000 total deaths from COVID-19. We average about 1,700 cases per 100,000 population. But the statistic I can understand is unfortunately 1,000 new per day, which is basically 9/11 every 3 days. So this is still a problem in the United States. Worldwide, Johns Hopkins has a really great tracker if you want the up-to-date information. There are 23 million known cases, so we take up about a fourth to a fifth of them. 800,000 total known deaths, and the new cases worldwide are 254,000, and new daily deaths are 5,200. So we really just need to keep doing those W's. Wear a mask, wash your hands, watch your distance, and I guess a D, don't touch your face. On a lighter note, Hindus around the world this weekend are celebrating the birthday of Lord Ganesha, who is the elephant-headed god who is depicted very classically in the setup at my house. But certainly in the time of COVID, I think this depiction that was sent to me by Dr. Arun Iyer in England kind of tells the story of what we need this remover of obstacles to do for humanity in this day and age.
Yeah, I think that's what we do need is we need the obstacle being the virus and how the pandemic is really affecting all of us. One of the other things going on right now is back to school, and I've read a lot of different articles across the country and across the world looking at schools and keeping kids in school and how important it is to prevent that ongoing summer slide. And I would say there's an online slide too, because the kids are not remote learning as well as we would like. And this particular slide is just showing how the national picture breaks down, that there's plenty that are hybrid, but the most seems to be primarily online. And so this really is, I think, what we're all facing. My kids are going back to college, and that's why you see a new location this week. And so they're going to be back in college, and one of them is fully online classes, and the other one is one in-person class out of the 4 others that she's taking.
Yeah, and I think, this will evolve. We saw that colleges opened and then closed, and we saw a lot of blame and shame being put on students who went in, and then, there were clusters in fraternity and sorority parties, there were clusters at bars. So even though there were precautions taken, let's say in the dorms or in the classrooms, we saw these clusters, and the colleges closed as quick as they could open. The problem is we're parents, right? You don't get anywhere heaping blame on people. Nobody changes if you heap blame on them. And there was a really good article, I think, for all parents who are struggling with how to balance our children's creativity and innovation and need to experiment with their safety. So there was an article by Julia Marcus, who's an epidemiology professor at Harvard, and Jessica Gold, who's a psychiatry professor at Washington University School of Medicine. And they wrote an article in The Atlantic about this, about how shaming somebody never works, but certainly educating people, having public health protocols of testing, tracing, isolation at the universities and in the communities where the universities exist really helps. And then explaining to these young people what they can actually do. So they can have smaller gatherings. They can keep a mask on and do some social distancing or physical distancing while they in fact have some socialization. So teaching them about social bubbles, providing them with guidance about how to congregate safely, I think really makes a difference, because we really want our young people to get the best college experience that they can at this time. Marina, you have pointed out several times, we keep learning more and more about COVID-19. It's only been around for 8-9 months now. Maybe you can talk to us about something we've learned that was recently published.
Yeah, well, so let's talk about, now that we're testing as our testing overall is better, we're finding a lot of people that are asymptomatic that are very positive. And the question is, if you're asymptomatic, can you still transmit? And the general feeling is yes, because you have a positivity. And so you are a silent spreader of disease. And as well, we have a slide that we can show. It looks a little confusing, but really the kids under 5 seem to carry a significant amount of the virus in their nasopharynx. So they actually may be a group that can really spread the disease as well. And this slide looks like they have, when you look at less than 5, it looks like they have the least amount. But what is the test that they did, basically it's showing that the threshold to identify the virus is lower with the kids having so much of it. And that's why it looks like a little bit off, then that it looks like the kids have the least, but they actually have the most virus compared to even symptomatic adults.
So we finally have a non-COVID story, and it's something I actually know something about.
Yes.
So you want to see it for me?
If you guys are eating breakfast, I would take a pause for a second.
These pictures are beautiful.
Most of the things that, as a general surgeon, I see, we're not going to show you colon or anything like that, but it's still a little bit of a shocker.
So America's infectious disease doctor, Dr. Anthony Fauci, who is the director of the National Institute of Allergy and Infectious Disease, which is part of the National Institutes of Health, has a raspy voice that we've all been listening to nonstop for 8 months. And Marina and I were listening to him way back in the bad old days of the 80s and 90s with the AIDS crisis. And so he sort of led our country through many infectious disease crises. And he's been sidelined this week by the development that was reported as a vocal cord polyp, which is a benign little growth on his voice box. So these pictures, which Marina is wrong, they are beautiful. The left upper one shows what a normal voice box should look like. The vocal cords are white and beautiful without any lesions. The right upper one shows a polyp sticking out of one of the vocal cords, and you can imagine that will prevent the cords from coming together well and will make airflow through that sound kind of raspy like this. The lower one on the left shows what acid reflux can do to your voice box, so that can give you a lot of hoarseness as well. And then the one on the right lower shows nodules, which we are on the vocal cords, and they're on both. They're that little bump on both of the vocal cords. And in adults, we call them singer's nodules. And in children, we call them screamer's nodules. And they occur, I know, we're really just mean to kids. I don't know. But they occur when you abuse your voice without warming up. So I'm going to give a little ENT PSA. So protect your voice, which means stay well hydrated. Don't strain your voice. If you're going to be doing public speaking or singing, warm up your voice. Avoid smoking or vaping. Avoid acid-rich foods that will cause reflux and mess up your voice so you kind of sound like this. And if you develop hoarseness, the guidelines from the American Academy of Otolaryngology Head and Neck Surgery say that you really should not let it go. If you develop a hoarse voice or your voice gets hoarse after only a couple of seconds of use, you need to make an appointment with your local friendly ENT doctor and have your vocal cords looked at, because we can identify and treat diseases early and promptly. So there's my little PSA on ENT, and there's my joy of being able to talk about something I actually know something about.
If you talk with that hoarse voice, you're going to get vocal nodules.
I know.
You have to stop it. All right, you guys, we're going to lead right into our show. We're so excited to have our two wonderful guests. Dr. Doris Day is a world-renowned dermatologist in private practice in New York City. As well as I told you, she is a host on Dr. Radio. We're so thrilled to have her. You guys remember Seinfeld when he was dating a dermatologist and he was like, "You're just a dermatologist." And she was like, "I save lives." And that's right. You save lives with skin cancer treatment and many other things that she does as well. Skin cancer is just a mere example. Also, Dr. Valerie Fitzhugh, Associate Professor and Interim Chair of the Department of Pathology at Rutgers, New Jersey Medical School, and she is a cytopathologist, and she's really changing the public's understanding of pathology one tweet at a time, not to mention that when we take out a lump or bump or a growth, anything that we, like even those vocal cord nodules, we send them off to great doctors like her who can let us know what's happening, and believe me, we totally rely on them for everything that we do. So they're like an unsung hero as well. So welcome to both of you guys.
Yay. Thank you. Thanks for having me.
Yes, thank you. Thank you so much for the invitation.
Okay. Can you guys, your Twitter handles are there. You guys who are watching, please follow them. Follow Sujit and I too.
Well, you'll learn a lot from them, because I think doctors are understanding how much we can teach individual patients, but groups of people about what it is that we do. So I'm so glad you guys are here. I'm just reminding you that we are live on all the social media channels. These women have a lot to teach us and a lot to talk about. So please like and share and tag your friends. We have people watching from all over the world today, and we really appreciate it. So I'm going to jump right into it because we had a slightly late start because of some technical difficulties. So Doris, can we talk a little bit about regular skin routines and skin cancer and what people should be doing and looking at?
Absolutely. A lot of times I get a question about like, when should we start taking care of our skin? When is anti-aging start? And I kind of jokingly say it starts at birth. As soon as you're out, the time starts ticking, and everything you do reflects in your skin over time. So when we talk about sun protection, that's the single most important thing you do for your skin. 90% of how your skin ages is in your control. Only 10% of how your skin ages is genetic. And that relates to skin cancer as well. You may have a few genetic hits towards skin cancer, which isn't always reflected by skin color or skin tone, or even how easily you burn. But the more you protect at a young age, it's physical protection. At all ages, it's about diet. But as we grow, it's really about being consistent in your sun smart behavior, which is so much more than just sun protection. It means trying to avoid midday sun, wearing a hat, wearing sunglasses, wearing physical protection when you can, staying in the shade, and then applying sunscreen of an SPF 30 or higher and reapplying regularly when you can. And of course, it means looking at your skin, because if you see something changing in your skin, it's on the outside. You should notice if it's changing over time. If it doesn't look right to you, show it to your dermatologist, because we'll either reassure you or we can send it to our friendly pathologist who helps us make a diagnosis. And an early diagnosis can be 98% or greater survival. And a late diagnosis, unfortunately, can be a lot of trouble and a lot of work, and often may really affect your overall outcome and survival.
Doris, it has to be 100 times worse for you. And I'm not sure, Valerie, if you can agree with this too. But first of all, I stare at people, right? Even when I'm talking to them, my friends are all like, "What are you staring at?" I'm like, okay. Not a big deal, but I think you probably should get that thing checked out. Like that one, that one looks a little funny to me. And I'm not a specialist at all, but what I want to ask you is, we're going to show a slide of the different types of cancers. And, because I've had people say, I had this red spot for a really long time. And I'm like, yeah, that one. Go see somebody, at least let them. I mean, I'm not a specialist, but if you're going to ask me, I'm definitely going to tell you to go see a specialist. But some of them you can kind of tell. So I'd love for you to take a look, and for our audience to see this, and these are, actually, I'm going to let you talk.
Okay. Well, we'll start with the first one. Actinic keratosis is really sun damage, an early sign of seeing atypical or cells that are on the way to becoming skin cancer, but not quite yet skin cancer. So that's a warning sign to us that somebody's on the way. And the thing is, this can happen in all skin types, although it's more common in fair skin. You'll see all of these pictures in fair skin because these cancers are more common in fair skin than in darker skin. So when you look at the totality of skin cancers, whether you're looking at melanoma versus non-melanoma, basal cell, squamous cell, all the ones we're going to talk about, 35 to 45% of all cancers are in the skin in white people. When you look at Hispanics, it's 4 to 5% of cancers. In Asians, it's 3 to 4%, and in blacks, it's 1 to 2%. So when you look at skin color, the rates of skin cancer go down, but it still needs to be diagnosed early. So actinic keratosis is sun damage that you can feel more than you can see. So it's often a rough spot, slightly red. When you go to the next most common type, that's basal cell. That's about 4 million cancers in a year. It's the single most common type of cancer, not just skin cancer, but any cancer. It's more common than breast, colon, lung, and prostate cancer combined. Wow. So chances are people are going to get basal cell. Again, I see this in people with skin of color, and what we have to look for is not the color of the spot, but the overall look. So basal cells can have rolled borders, they can have a pearly look to them, they can be pigmented or non-pigmented in any skin type. So just because you have skin of color doesn't mean you're going to have only a pigmented basal cell, and because you have white skin doesn't mean you won't have a pigmented basal cell. So we need to pay attention to spots in the skin that are growing or changing and evolving over time. Then let's go over to squamous cell, because that's the next most common type. That's about 1 million new diagnoses every year. It can have a little bit of an ulceration or a scale in the center with redness at the borders. Melanoma is the one that scares us the most because it's the least common but most deadly. Over 100,000 of these every year, and about 1 to 2 people die every hour of melanoma. I had a patient who was African American who came in and he had vitiligo, and in his white spot he had an amelanotic melanoma. So it looked like exactly what you were talking about, a pink spot, but it started to grow over time. And they just sat there and they watched it because they thought because he had vitiligo and because he was African American, they didn't think that they were at risk of getting melanoma. And so unfortunately it was late. He's still doing fine, but it was work to get him on the treatments to help save his life. And we have amazing new treatments. Merkel cell is the one type of cancer that makes me tell you that you should have your skin cancer screening done by a board certified dermatologist every year. Merkel cell is the rarest of skin cancers. It's not sun-related. It can happen in any skin type, and it can kill you in as little as 3 weeks. So, and it doesn't have a typical look. It can look like a cyst. It can look just like a bump in the skin. Depending on where it occurs and how fast it grows, it can be very deadly very quickly. So it's every time I look at the skin, every time I look at a spot, I'm sort of having a conversation with it and saying, are you a Merkel cell?
So when you have a suspicion, maybe that's when we can turn to Dr. Fitzhugh and say, so what can a pathologist do to help us understand what's going on, and what is it that you're looking for when that biopsy comes from Dr. Day and you're looking at it under the microscope?
So when we receive usually a biopsy from a patient where we're concerned about skin cancer, there's a whole processing that the tissue goes through where we embed the tissue in a paraffin block, and then we make very small sections through that block to create the slide. Those slides then get dyes applied to them so that we can look under the microscope and see the different colors. When we're looking under the microscope, what we want to see is whether or not the tumor has broken through something we call the basement membrane. So if the neoplastic or the tumor cells are above that basement membrane, it's still contained and it's not an invasive cancer. But once that tumor has broken through the basement membrane, then you're dealing with invasive cancer. And that's what we see in squamous cell carcinomas, basal cell carcinomas, melanomas, and Merkel cell carcinomas. So it's important and essential for the pathologist to look at that skin sample and figure out how deep those tumor cells are going. The cells all look differently under the microscope. Sometimes, as Dr. Day mentioned, melanomas may not have pigment. So we have a trusty arsenal that we can use to figure out what the cell types are, and we can make an appropriate diagnosis and help the patient get their best care.
That's fantastic. And we as physicians, when we get that back from you guys, that really drives our care. If something's superficial, the depth of penetration, as you said, is so important to what our ongoing treatment is. And also, many of our viewers may have experienced this themselves or heard about it when we talk about negative margins and positive margins or close margins. Valerie, if you could just discuss that as well.
So a margin is something that you'd like to, is an area away from the tumor that you'd like to get that has no tumor in it. So if you get a pathology report that says the tumor is within, 1 centimeter of the closest margin, that means the tumor is 1 full centimeter away from the edge that the surgeon has removed. 1 centimeter sounds small, but in the microscopic world, 1 centimeter is a good sized margin for a skin cancer. We often see margins as wide as 2 centimeters for a skin cancer. And that's important because then we can say to the surgeon, yes, you got it all out, and now you can do whatever else you need to do to help treat this patient. So margins are very important.
I think this is really crucial because I think when patients come to us for care, whether it's for a skin lesion or for other lesions, and we say, well, we're going to send it to pathology, that's where the dialogue continues, where I think pathologists really have to understand the whole body and what, in the ear, a 1 centimeter margin is enormous, whereas in another part of the colon, the 1 centimeter margin is doable. So I think this is where patients have to understand that we actually talk to each other a lot, and that each of us tries to know as much about the entire body as possible. There's something we've been dealing with as COVID's gone by, which is much less serious than cancer, but is really irritating. And that's, it's been given a name called maskne, which is the acne that you get from wearing a mask all day long. And, we wear masks all the time to operate and do things, but this has gone to another degree. So maybe Doris, can you talk to us about maskne and how do we keep our lovely skin from getting this?
Absolutely. I like that we call it maskne because it's different than acne. And so we don't want that exact confusion. It's a breakout, and many breakouts in the skin can look like acne, but they have different underlying causes. So when we talk about acne, it's a very specific process where we know that there's this bacteria at the base of the follicle, now called C. acnes, that can cause some inflammation and an inflammatory response that we see all the steps, whether it's a pimple, a blackhead, or whitehead, that we know of as acne. But when you wear a mask, what's happening is slightly different. You have a few factors going on. One is you have the actual just friction of the mask on the skin, which alone can cause irritation and a breakout. The skin's not designed to be covered in that way. It's really designed to be exposed. And then depending what the fabric's made of, you can have more or less friction. So the fabric that you use in the mask can be very important depending on your skin type. The next is the humidity that's coming from your nose and your mouth naturally as you breathe. And that humidity can be now causing occlusion, where it's forced back onto your skin and can create, and then there's bacteria and yeast that grow in that can now implant back in your follicles or on your skin and cause overgrowth of those infections in the skin, especially if you have a break in the skin from the friction that now makes you more predisposed to that type of infection. So what you need to do is wear a mask when you need to and not when you don't. A lot of times, I feel so cautious in telling people how often to wash hands or when to wear a mask, because I don't want for people to think that they don't need those things. You need to wash your hands, you need to wear a mask, but people tend to take that to the nth degree because they don't understand exactly when they should, so they overdo it in that way. And that's always safer if you're unsure, but I can give you some parameters. If you're out by yourself and you have great social distancing, or if you're in your car by yourself, you don't necessarily need a mask. If you're in a crowded space, or if you're in an environment where you can't avoid other people, you absolutely need to wear a mask. So there are boundaries, and I think this is something that's important to do, is sort of set those boundaries of when it's important to wear a mask so that people can understand the safety aspects, but not feel like if they're not wearing one, the virus is going to come and find them and attack the skin. The virus isn't that smart. It's really opportunistic. So you need to sort of be at a place where you're in its way more than it coming to find you. And I hope that helps people. But then in how you take care of your skin, gentle cleansers, don't use aggressive exfoliating products because that's going to cause more breakdown of the skin. You want to preserve the skin as a barrier. And I'm actually making something, I'm trying to decide on the name versus Clear Day or the Day Mask, something you'd put on underneath your mask to create a barrier protection that also has some zinc and other ingredients that can help against breakouts and infection, because we do need something that's antiseptic but not harmful to the skin that can create a barrier. But until then, gentle moisturizer, gentle cleanser. Think about the fabric you're wearing. If you're seeing irritation, try a different mask, and make sure you wash your mask often if it's a washable mask, and change your mask often if it's a disposable mask.
It's so many people have heard so many different things about what masks to wear, et cetera. So it is confusing, but if some of the data's come back now a little bit 180. They were like, oh, cloth masks not as good. Now they're like, no, cloth masks, go ahead and use them. So those are
how do you feel? The way that I see it is it's really stopping droplets. We're not really thinking about the tiny viral particles, which can possibly go through or around most of the masks. They're not necessarily tested for that. It's really designed to, one, keep you off your face, and two, from when we speak, all the bigger droplets that may come out from reaching away from our face or somebody else's droplets reaching our face. So just about any face covering will do a reasonably good job of that, and certainly is better than nothing.
I couldn't agree with you more. I believe in masks. I ended up buying a bunch of cloth masks for the kids as they go back to school. Valerie, I want to ask you about you're subspecialized in pathology. You're a cytopathologist, even though you obviously probably see cases of everything. Can you talk about that? And basically, you're looking at cells for our viewers. Those are patients who, when you go in, you have a thyroid lump or some other thing, and they stick a needle in it and draw breast masses as well. They stick a needle in and draw out some cells and then send it off. And the person who's on the other end is hopefully as fantastic as Valerie, but they're all looking at that and making a decision on what what that mass actually is.
Absolutely. And the fun thing, that process that you just described, Marina, is called fine needle aspiration. And in that process, and actually, I have to do a PSA for pathologists now. There are pathologists like me, cytopathologists, who are trained in fine needle aspiration. That's how I got my Twitter handle, Dr. FNA. That's where that comes from. And so it could be any type of physician who is trained in the process of fine needle aspiration. They take a small needle, a very small needle, so don't freak out, everyone. It's small. And we can stick that small needle into the mass, and it allows us to then draw back some cells that we put onto the slide and also into a certain type of fixative. And by doing so, it allows us to then take the slides or have the slides sent to the laboratory where a pathologist can look at it. Sometimes we actually do it on site in the room in front of the patient. So they actually sit there patiently waiting for us while we stain our slides and then look at them under the microscope. And we can tell the patient if we have enough cells to make a diagnosis for them. So it can be a very fun experience for pathologists. You know, we don't get to see that many patients, but for somebody like me who actually does crave that patient interaction, it's a lot of fun, and I really do enjoy it. And it's nice to have a hands-on relationship with the patient. It really, brings that feeling of patient care home. So we make a diagnosis, usually, within a final report within a day or two, and then the patient can go on with the rest of their care.
So I have to tell you, having been trained, in the dark ages, we used to do our own fine needle aspirations, and it is really better to have somebody who's really good at it and who can actually, as Valerie said, let you know that you have enough cells. Because if by accident there's some blood, then the thyroid cells are kind of washed out, and then 2 or 3 days later you have to bring the patient back in. So I really love it, and I think that it gives us a much better sense of what's going on and how we treat the patient. The other thing that people don't understand, there's so much people don't understand about pathology, right? There's a big joke where there's some birds flying in the air and the internist is, I wonder what that is, and it has this kind of plumage, and the surgeon just kind of shoots it and takes it down and hands it to the pathologist and says, hey, tell me what this is. Okay, come on, it's against us, all right? So, but lots of things happen in that black box of the pathology department that we really don't understand. One of that is about COVID testing. So we know about sticking a Q-tip up your nose. We know about getting some blood tests. Can you tell us, and I know, Valerie, you were on a great podcast that we'll show in a bit, but these are sort of the things people want to know is, what are these tests doing, checking for? What are they telling us in this time?
So let's take a step back and look at what the coronavirus actually is. We've seen pictures of that spiky little virus, coronavirus, because it looks like a crown, corona. And so when we're testing for coronavirus, there are different ways to do it. The most common way, of course, that we've heard is the swab up the nose, which is what we call viral RNA or ribonucleic acid test. And in that test, you try to get direct viral particles from the organism. We amplify them, and then we can tell whether or not a patient has the virus detected or virus not detected. So if the virus is detected, then you have a positive test for COVID-19 or SARS-CoV-2. But there are other tests out there, and that's the most common one that we're using. It is by far my favorite, no plug for any corporation, but it is a great test. The antibody test, which many of you have also probably heard about, tests antibodies. So what's an antibody? An antibody is a substance that we create in our bodies when we're exposed to an antigen. So what's an antigen? An antigen is a substance on that virus. So there's a substance on that virus that creates a reaction in our bodies with our immune response to create antibodies. All of these can be tested for COVID-19. Again, in my humble opinion, I think the best test is the viral RNA test, and the one that I would recommend people get if they believe that there's COVID positivity. Now, there are 2 types of RNA tests. There is the nasal swab, which is, I've had it done. It's a little uncomfortable, but it's not the end of the world. The other test, which was developed here at Rutgers University, is the saliva test, where you can bring up a bit of saliva and put it into a tube, and they can detect the viral RNA particles that way. It's much less invasive. It takes about 10 minutes to get a good sample because your mouth does dry up while you're doing it, but it does allow for detection of that virus within the saliva.
we all heard about the saliva test, and for those of us who have undergone the nasal swab, it's quite different when I'm going to my colleagues and friends, the nurses, like they got, during the height of the pandemic and quarantine, our nurses that were in the OR got rerouted or deployed to other areas. And so I'd show up to get tested, and it'd be like one of my OR nurses, and I'm like, dude, do you know how to do this? And they're like, yeah, we're good. We've all been trained. Well, that thing goes so far back to your nasal pharynx. It does feel, as many people have said, like a brain biopsy, right? But then what I saw is one of my colleagues who is a plastic surgeon, he showed me his niece had gotten a swab from her college, and she videoed it, I guess, to send him and say, am I doing this right? And she just put it in her nose, but it wasn't the flexible brush that we use for, testing at the hospital. It was just like a regular Q-tip, and she put it in, and he's critiquing it going, I don't think it went in far enough. And I'm like, I don't think that can go in too far because it'll break off, and then she'll have to go get a foreign body out of her nose. But so some of that testing is still so uncomfortable. So I was telling my kids, they're like, what's this saliva test? Why can't I get that? I'm like, because it's not readily available. And, you still need a deep sample. And the boys, they're like, we can hawk up a loogie, no problem. Like, we can get this out, and gross. But even my daughter was like, yeah, I can muster something up, like that would be much preferable to this probe down the nose. So the sensitivity of that saliva test, is it as good as the PCR testing? And so just as a background for everyone, when the nasal probing swab was first introduced, we still had a 30% false negative rate, meaning that people would come in that were symptomatic and they would be told, well, you don't have COVID, even though they might seem like they have classic COVID symptoms. So is the sensitivity better on both the PCR testing by the nasal swab, and also how about the sensitivity or false negative rate with the, which are two different things, I know, Val. I know. But is that improved, or what is it? Especially since it's made in New Jersey.
So the sensitivity of both the nasal swab and the saliva test are actually quite excellent. One thing that's important to remember is the saliva test is also a PCR test. So they're doing a similar test just on a different substance in the body. These tests are very, very reliable. The patients do very, very well. One of the issues that we see with, false negatives, if you will, are collection. So as you mentioned, did the swab get up high enough? Do you have enough saliva to detect the viral RNA in the sample? Other issues we face are testing patients early. So in the early part of the disease, they may not have built up a sufficient, what we call viral load. So they may not have enough viral particles to be detected. So if you test them on, say, day 2, they may be negative. But if they come back on day 8, they'll be rip-roaringly positive. So timing of the test is also very, very important. But the tests are excellent and have a very good detection rate for COVID-19.
So that's really great, because I think we were struggling with false negative testing where the patient is actually sick, but we weren't able to prove it, and we couldn't. It was a big struggle in the beginning, and I think this shows how rapidly medicine has actually responded to this crisis. We have people watching from all over the world. My colleague, Dalisa Gonzalez, is an otolaryngologist in Nicaragua. We have people watching. Mark Lee's watching from North Carolina. We have people watching from Virginia. We have people watching from all over the world. And Isra just asked about the saliva test versus the nasopharyngeal swab, even from White Plains. And thank you so much for answering that. We had a question that was sent in earlier by one of our viewers. Her teenage daughter is Indian American, and she was born with some patches of vitiligo, and they are now growing or increasing in size. And she wants to know, Doris, what can she do about them? What should she do about them? What can you talk to us about vitiligo? We had a slide up earlier looking at vitiligo in different ethnicities, and I think perhaps you can talk to that.
Sure. I wanted to make one quick point about the saliva test, if that's possible. One thing I heard, and I wanted to see if you agree with about the saliva test is that while it has a lower sensitivity, it's what you were saying, Valerie, about catching people who are in their more contagious state, and it's a lot less expensive of a test and can be done at home. So I think it's about $1 to $2 per test, and you could even kind of group collect sputum and put that test strip in that and see if it comes out positive. And if it does, then you can test people. So even though it's a lower sensitivity, it's not a random lower sensitivity. It's missing people who may have been exposed but are not really contagious, and catching people who may be rip-roaring contagious. So it may be a nice fix because it's so inexpensive. It can be done right at the point when you need to, before you go to school or go to work or play in a team sport. And you can isolate people who may be contagious. So it might be helpful as a fix in the middle. Because I think when we talk about sensitivities and we go, it's less sensitive or it's only 50%, we think, oh, it's not good, but it's not random, right? So that's a point I wanted to make. I wanted to know if you agree. Oh, and then I'll talk about the vitiligo. So for vitiligo, I have opinions on everything, just so you know.
I love that you're interviewing Valerie, because Marina and I are just going to go for a cup of tea right now.
No. It's great. You should ask her. What I'm saying is New York State has also talked about that pooled saliva sample. And so if you have 10 people that you're in contact with your palm or your bubble, then you all spit in a cup, which is gross. But those pool, or you send it all in together, but separately, and they pool it. And if there's one person that's positive, then that means that everyone should quarantine. So
right.
And so, what do you think, Valerie? What do you think of that?
So with pooling, I mean, what's important with pooling, one is that you will increase the turnaround time of the test, because if you have 10 samples that are collected separately, you pool them together and you find that sample now becomes positive. You now have to test those 10 samples individually to figure out which person was the positive one, so that everyone isn't unnecessarily quarantined. So that's one thing. Another thing that we have to pay very close attention to with pooling is that if a person, going back to that viral load issue, if a patient has a very, very low viral load, you can miss them in a pooled sample. And so you can have someone who's actually positive but won't test positive because the volume of virus, again, is too low to detect. So, we're looking at pooling.
But do we care if it's too low to detect? Because then they won't really be contagious necessarily. That's my thing, is that we're testing so strongly.
They might be contagious. That's the problem. Because when you take a pooled sample, you're decreasing the amount of virus RNA from the original sample.
I see. That makes sense. Yeah, I get that. Thank you. All right, this is why I'm sticking to dermatology. Okay, so vitiligo, there's about 200,000 cases diagnosed every year. And it's an autoimmune condition where your own body's immune system thinks that the pigment-forming cells, those melanocytes that give your skin color, are foreign invaders, and then they go to attack them. And we typically see it, like you see in these pictures, around orifices, around the eyes, around the mouth, on areas of high friction, because there can be more inflammation in those areas. And it is very bothersome to people in whom it occurs, but it's not a sign of a systemic problem. So when I see somebody with vitiligo, I go through a whole differential diagnosis in my mind of what the possibilities are of what it could be. Is it vitiligo? Is it a post-inflammatory process after an infection or breakout, or even a medication or some other things that could be causing it? Because some medications make you more light sensitive and you can burn, and as a reaction to the burn, you may actually lose some pigment rather than gain pigment sometimes. Or could it even be some infectious diseases? So there's a lot of things we think about when we see vitiligo. But once we diagnose it as vitiligo, which our awesome pathologist helps us do, and when we send cells to the pathologist or we do a little biopsy, we have to be very careful to treat that sample beautifully without crushing it. So the way we do the biopsy is really important, so the pathologist doesn't call us back and say the specimen was crushed or there weren't enough cells or wasn't enough tissue. And we think about what the pathologists are saying behind our back all the time. And then we can do things about it. So treating vitiligo now is coming to a better level. So in the past, we would use topical steroids, some topical steroid sparing agents like tacrolimus, which had varying degrees of efficacy, depending especially on the body surface area we were using. Areas like the hands didn't respond very well. The face often responded better. Some parts of the body didn't do as well. And when you have it in one spot, it doesn't mean that it's going to spread throughout your whole body. It's not a progressive condition necessarily. So if you know somebody else with it, it doesn't mean you're going to end up there. If you have one spot, doesn't mean you're going to get many more. And if we treat one spot, doesn't mean we'll stop it from happening somewhere else either. So we have to take it on a case-by-case basis, see how much it bothers you. We do basic tests looking for other autoimmune conditions. It doesn't cause other autoimmune conditions, but they can be associated. So we ask questions about thyroid. We look for things like psoriasis. We look for family history of vitiligo and other autoimmune conditions. And then we look for treatment plans that might help. The new thing for vitiligo is that there are now biologics, things like the JAK inhibitors that were used to treat arthritis that we now have found help with hair growth in people with an autoimmune form of hair loss called alopecia areata. And we're finding that some people with vitiligo are also repigmenting. So they're looking at this as a pill, but also as a topical agent to see if it can help those cells recover. And then we use light. We use UV light, narrowband UV light, sometimes with a light activator to try to help repigment and stimulate the cells to start making pigment again and turn off the inflammation that's knocking out those melanocytes that we need to give us our skin color.
You know, a few things. One of our viewers just said, thanks so much for the information. And it's Ty Stokes, and she's going to go see the dermatologist or make an appointment with the dermatologist tomorrow. So that's fantastic.
Great.
You know, there was another comment from Isra Paranon about how, you know, it was a good point to bring up, Doris, because if the tests are actually cheaper, then it can get into communities that are perhaps, you know, more at risk, and that would be great also. So if you guys are watching, definitely like and share so that your friends can get in on this great information as well. As you know, we are live right now, but you can also get our archives at She's on Call on YouTube and Twitter. And the one thing also that I loved about that last one with all the patients with vitiligo, like when I was a kid and I first saw it, I was taken aback, and I was a kid and I would stare, and yet those pictures really showed the beauty of the person, right? And that it's so hard when you're being stared at, but when you see those pictures, they're really beautiful people, and it was more an interesting, you know, if we could just look at it as like they're different but not different, you know, it would just be so much better.
I agree. I sometimes tell people, especially kids with vitiligo, that they have a superpower, because people will look at them and some kids will make fun of them for having it. And I said, you get to know that those people are not nice people right off the top. The rest of us have to kind of figure it out. We can't tell right away, but you get to see who's a true friend and who sees your beauty versus who's weak and who isn't a good person. So we try to turn everything around to the way that you put it. I love it, is everyone has beauty, and it's about seeing your beauty in all things. And then if some people choose not to treat it, and that's fine too. You don't have to treat it.
I thought it was interesting that you can get repigmentation, but does it fully go away in some people, or is it a matter of early or later?
No, it can. Well, earlier is always better when you try to treat vitiligo. So the sooner that you know you have it, if it really bothers you, get to the dermatologist, because you can talk about treatment options. The longer you have it, the more pigment burnout there may be and the less chance, although we've seen it come back after years, so it can still come back no matter how long you've had it. And these JAK inhibitors are really showing that, because, you know, the pigment cells are at the base of the hair follicles, and you're covered in hair follicles and pores. And so if we can re-stimulate the pigment cells at the bulge area of the follicle, those stem cells, to repigment, we can get the pigment back exactly as it was. And also, if you have vitiligo, you are more sun sensitive in those areas because you don't have those pigment forming cells, those melanocytes, to protect you from UV rays. So you need to be extra careful about sun protection in those areas.
That's a really important point, I think. And I think people of color also don't realize that they do have to protect themselves. And what you said earlier about 90% is preventable. 90% of skin lesions are preventable. Like, I know I wasn't born with these freckles, right? So I wish I had known you when I was little. We're getting some great responses. Helma Paulo Ali, who's watching, said, thank you for the amazing response to children, Dr. Day, and even for adults. And I think we've mentioned on this show several times that physicians are in fact social justice warriors, and we are there as the advocate for our patient, whether it's the person in front of us or the community. And segueing into that, Valerie, you have done some amazing things on Twitter. You've advocated for not only teaching pathologists and other physicians about pathology, but about advocating for hashtag Black Women in Medicine. And you got a NASCAR driver on your team and got him to get his friends on your team. So can you talk to us a little bit about that?
So, this is very, very funny and very interesting. The night before my birthday, I decided that I was going to ask Bubba Wallace to follow me for my birthday. And I've been watching NASCAR since I was in middle school. So I've grown up on it. And when Bubba came onto the scene in the early 2010s, I was excited because I said, hey, look, there's somebody there who looks like me. And it's such an unusual thing, unfortunately, to still see in auto racing. So it was just so exciting to see him. And of course, you all know he's blown up. So hashtag MedTwitter got to work on my birthday, and a bunch of people tweeted at him and retweeted the tweet. And sure enough, he made a little video of following me on my birthday. So that was pretty awesome. And it turns out that he's actually very, very kind, wonderful man. Every once in a while, I'll send him a direct message that he'll answer. And so one of them was about, the HBCU movement and how, there have been women scientists, particularly Black moms, who have had their research halted, and it's very difficult. Now we're staying at home with our kids and trying to take care of things. And so, I said to Bubba, essentially, no pressure, but if you can donate to this worthy cause, we'd really appreciate it. And so not only did he donate, but then he got Tyler Reddick and Ryan Blaney to donate as well. So we had 3 drivers who donated to the cause. It was really awesome and much, much appreciated.
So can you tell our viewers how to donate and what the cause is for?
So the ARM, we call it the Army, Academic Research Moms, have a fund for medical and research trainee moms. It's on GoFundMe, so you can see it there on your screen. We have a goal of trying to raise $60,000 for these research moms who have had their research halted because of the COVID pandemic. So if you can get on GoFundMe and look for the ARM Fund for Medical and Research Trainee Moms, that would be awesome. And we appreciate anything that anyone can give.
Thank you so much. I think we're going to run out of time, which is so unfortunate because, oh my God, you two are amazing. We're going to go a little bit late because we had some technical difficulties in the beginning. So we have about 9 more minutes with you guys. But Doris, you are an entrepreneur. You have an incredible dermatology practice in New York City, and you've written a number of books. Can you talk to us a little bit about juggling all of those hats that you wear?
She's also a mom. She's had her kids work with her. I mean, she's just been,
Thank you.
All of us have our kids work for us. It's the new child labor, right?
You guys are better. Yeah. My kids refuse to work for me, or they're like, what? My daughter said that's a lie. She actually did come to the office. She's the best. My daughter's the best.
Yes. Well, I've been very fortunate that I have had great support through my whole career. It's my anniversary month. I've just been married 30 years, which is really exciting because we still like each other, which is a great thing. And I started out as a medical journalist and writer. So that's been something consistent through my career. I've always liked educating both my peers and the public. And if I know something, I want to tell people what I know because I love learning, and I'm sure other people do too. And when you understand something, you're going to follow through much better. So one of my skill sets has been, as a middle child, maybe, I don't know, of communicating, not complaining, but communicating. And so I try to communicate what I know in ways that are relatable and understandable. And that brings me joy. Also, I've been doing the radio show on Sirius, as you have, for over 12 years, and I love that as well. And then in terms of the balance part, it's really about understanding that you get one life and there's one of you in 24 hours in a day. So how do you put all those things together? And I don't think on the one hand, you have to compartmentalize, and wherever you are, be in the moment of that one thing. And on the other hand, understand that it's all one. And it's not work and life, it's all life. So my kids and my family were very much incorporated into what I was as a doctor. I learned from my dad that you don't go home and stop being a doctor. As a physician, it's a calling. So it's who we are, it's in our blood, it's in our being. And our children get the benefit of that because they learn from us. And now my daughter's in medical school. She was in finance and quit to go to medical school. My son was the other way. He was pre-med and then quit to go into global security. So they don't always follow, but as long as they are fulfilled in their lives and productive members of society. And I told my kids, you won the lottery at birth. You're born to a family that loves you and can provide for you. Now go out and earn it. Now go earn that lottery ticket that you won and be a good person and give back to society. And that's what we hope for. And with patients, they are my family. And seeing my patients for me is as important as anything else I do. It's probably the single most important thing I do. And it brings me so much joy to see the difference in their lives and to watch them grow. I have patients who I saw as kids who have then worked in my practice and now are on their way to medical school. And then they grow up and have kids, which doesn't make me feel old, surprisingly. It makes me feel good. And it's just all one. And that's how I think you need to look at it.
Well, first, happy anniversary. And second, Vasanti's watching from California, loving our show. Thank you so much. I think, Valerie, you're at a different stage of motherhood. Maybe you can talk about that. And then in the few minutes we have left, I really do want to talk about another topic with regards to racial disparity and skin lesions.
So my mommy journey is a bit different. My kids are small. My daughter is 6 and my son will be 4 tomorrow. Happy birthday, Victor.
Happy birthday.
And so I am in a very different place. And, so I've taken a lot of things to heart, particularly with COVID. And do you send your kid to school? Do you send your kid to daycare? What do you do? How do you think about it? And I have wrestled so much with that because, I'm in a very different place. But I also said, my former boss, before I became interim chair, I said, no matter what you do, please don't mommy track me. I was like, I can make all of this work. And I think I have. And it's something that I'm proud of, especially for my daughter to see what she can become. For little black, brown and black girls who look like me to see what they can become. I think that's just so important. And so, my kids give me strength. They give me life. They bring the joy and the humor into my world that probably wouldn't otherwise be there. And I have luckily a very supportive husband who has been wonderful and has taken on so much with fatherhood and has done it so incredibly well. And I couldn't imagine this journey without him.
So in this article in Forbes that you were interviewed for, I love this article, and I think that this time is the time for all of us, black, white, brown, yellow, whatever, male, female, transgender, all of us to speak to our experiences. And here you said, quote, I found myself in an intersection between my race and my profession. What did you mean by that?
So, I always say I was born black and I will die black, and that will never change. But what was interesting, when George Floyd passed away, and there was this initial report that had come out, which was more like a press release. It wasn't from the Hennepin County Medical Examiner's Office. And of course, it got everyone in a uproar because, there was no talk about homicide. There was no talk about, how we all saw George Floyd actually die. And I knew as soon as I read it, there was no way that was going to be released by a reputable medical examiner's office. And so I took a calculated risk and I took to Twitter and explained why I felt that we all needed to be patient and wait, because a reputable medical examiner's office would not release that kind of data. And sure enough, the following Monday morning, the official report came from the office, which clarified everything. My fear in speaking up so early was that I would be accused of not being black enough, that I was abandoning my people for my profession, which of course I would never do. And so that was my intersection, and it was a risk. It was a calculated risk, but one that I was willing to take to educate people to understand how important it is to wait for an official report from a medical examiner.
Valerie, thank you so much for that. And if you guys follow her on Twitter, you can also continue to see the advocacy. And I love the way that you also used #MedTwitter for your birthday. Hello. All you doctors who are watching, there's something to be said for that. It's wonderful. I want to thank our guests again, Dr. Doris Day, world-renowned dermatologist. You guys have benefited from her expertise today. Thank you so much for joining us. And Dr. Valerie Fitzhugh, she's the interim chair, anacytopathologist, and as you heard, a Twitterati, and for valid reasons. And we want to thank our production team, our co-executive producer, Dr. Sri Srinivasan. He almost made Dr. Producers Rose, Vandana, and Julia. Rose is tweeting away for us. Vandana and Julia are making everything happen. I want to thank, obviously, Sujana. Thank you so much. We've had such a great time doing the show. And our next show is coming up next week. It's like 11 to 12. And we have some great guests. We have a colorectal surgeon coming on, as well as we have a rehab medicine, where we'd like to talk about some of the patients that had COVID who are actually not recovering, and we're calling them long haulers. So we're going to be talking that with Dr. Monica Gutierrez about that.
So thank you both very much for joining us. We could talk for 2 more hours and so many topics, and we'll just have to have you back on again. Thank you, Helm Apollo Ali, for saying great show, and guests always illuminating in so many ways. So thank you guys very much. Stay safe, and thanks.